Endoscopic submucosal dissection of duodenal Brunner gland mass using transpyloric traction wire fixation. One of the rarely described subepithelial benign lesions of the duodenum is a spectrum of benign Brunner gland proliferative lesions. This spectrum consists of 3 lesions: Brunner gland hyperplasia, adenoma, and hamartoma. All of these lesions are benign in nature, with a negligible risk of neoplastic transformation, but they can grow quite large and cause symptoms. Here, we present a rare presentation of duodenal Brunner gland proliferative lesion and our approach to treat it endoscopically. As they grow, these lesions can develop into long, finger-like masses that span from the duodenal bulb to the distal duodenum. These lesions tend to be highly mobile, and in the narrow duodenal lumen, it can be difficult to determine their exact site of origin, making snare resection or traditional ESD technically challenging. The patient is a 49-year-old female who presented with intermittent gastrointestinal obstructive symptoms, including postprandial fullness, epigastric discomfort, and intermittent nausea. EGD showed a large pedunculated mass extending from the duodenal bulb to the third portion of the duodenum. Then she was referred to us for further management. The origin of this mass was difficult to visualize endoscopically. EUS suggested that the tumor originated from the deep submucosal layer. We elected to perform a traction wire-assisted ESD resection. First, the lesion was dragged into the stomach through the pylorus using grasping forceps. The first clip was attached to the free end of the lesion. The second anchoring clip grabbed the wire and was deployed at the anchoring site on the gastric wall. We chose the traction wire method over the clip and elastic band system because it is longer, offering more flexible placement and stronger traction compared to the clip and elastic band system. The incision line at the lesion base facilitates the closure of the mucosal defect after resection. The lesion stalk was injected with a viscous fluid. We used a needle tip knife to create our initial mucosal incision. We made a semicircumferential mucosal incision of the stalk of the lesion. The dissection plane was stable and easily dissected due to the tension applied by the traction method. This technique also helped in visualizing any source of bleeding and control it in a timely manner. After our initial submucosal incision with the needle tip knife, we switched to an insulated tip knife to complete the submucosal dissection. The settings used during this ESD procedure were endocut and precise sect. Eventually, the lesion was completely detached from the duodenal wall. The combination of needle type and IT knives was chosen for procedural efficiency and familiarity, offering precise cutting and effective submucosal dissection. A scissor-type knife was considered appropriate for this case, but it was not used due to operator preference. The post-resection site on the duodenal wall did not show any signs of bleeding. Then it was closed successfully with 3 endoclips. To reduce the risk of post-operative bleeding, a viscous solution of synthetic peptide was applied to the resection site. Finally, retracting the scope from the duodenum to the stomach showed the resected lesion, attached to the gastric wall via anchoring endoclip. Then the anchoring endoclip was detached from the gastric wall, and the whole lesion was removed completely through the patient's mouth. This resected 6 by 2 cm gross specimen was sent to the pathology lab for evaluation. Pathology showed a prominent Brunner gland proliferation with overlying gastric patchy fibular metaplasia and reactive epithelial changes. Following complete endoscopic resection, the patient experienced complete resolution of symptoms immediately after the procedure, with no recurrence of pain, nausea, or early satiety during follow-up visit. Surveillance upper endoscopy was done 1 year after the ESD resection, and the resection site showed no recurrence. We are planning to repeat another surveillance EGD in 3 years. Transpyloric traction wire anchoring assisted ESD is an effective and safe approach to remove large pedunculated duodenal masses. The procedure time was short, lasted for 24 minutes. The endoscopist was able to achieve excellent post-resection local homeostasis with rapid recovery of the patient.